Hi class, this is Oluremi Akintola. I'm going to be presenting this discussion titled Gestational Thrombocytopenia. Gestational thrombocytopenia is the most common cause of thrombocytopenia during pregnancy, accounting for approximately 70 to 80% of all cases. It is defined as a platelet count below 150,000 per microliter occurring during pregnancy in the absence of another underlying cause. The condition typically develops during the late second or third trimester, and it is usually mild, with platelet counts remaining above 70,000 per microliter. Most women are asymptomatic, and the diagnosis is often made incidentally during routine prenatal lab testing. The prevalence of gestational thrombocytopenia is estimated to be approximately 5 to 10% of all pregnancies. Although the exact mechanism remains unclear, several physiological changes of pregnancies contribute to its development. These include increased plasma volume resulting in hemodilution, accelerated platelet turnover, increased platelet activation, and enhanced splenic sequestration. Unlike immune thrombocytopenic purpura, gestational thrombocytopenia is not caused by autoimmune disruption of platelets and does not typically place the fetal at risk for thrombocytopenia. Several factors increase the likelihood of developing gestational thrombocytopenia. These include multiparity, previous history of gestational thrombocytopenia, and advancing gestational age. Women who experience gestational thrombocytopenia during a pregnancy have a higher likelihood of recurrence in subsequent pregnancy. However, the condition is generally benign and does not increase maternal morbidity when appropriately monitored. Unlike immune thrombocytopenic purpura, gestational thrombocytopenia is rarely associated with neonatal thrombocytopenia. Neonatal outcomes are generally excellent. There is no increase of fetal growth restriction, preterm birth, or fetal hemorrhage. Attributedly so Patients with gestational thrombocytopenia are usually asymptomatic. Positive subjective findings may include a previous history of gestational thrombocytopenia in previous pregnancies. Relevant negative findings include the absence of gum bleeding, epistaxis, easy bruising, petechia, heavy vaginal bleeding, or other signs of abnormal bleeding. Patients with gestational thrombocytopenia are usually asymptomatic. Positive subject findings may include a previous history of gestational thrombocytopenia in previous pregnancies. Relevant negative findings include the absence of gum bleeding, epistaxis, easy bruising, petechia, heavy vaginal bleeding, or other signs of abnormal bleeding. Objective findings commonly include mild isolated thrombocytopenia discovered during routine prenatal lab testing. Platelet counts are usually between 100,000 and 149,000 per microliter. Relevant negative findings include normal blood pressure, absence of proteinuria, normal liver function test, and absence of splenomegaly or hepatomegaly. These findings help distinguish gestational thrombocytopenia from other serious pregnancy-related disorder. Differential diagnosis (ITP). Immune thrombocytopenic purpura is an autoimmune disorder characterized by antibody mediated platelet destruction. Unlike gestational thrombocytopenia, ITP may occur before pregnancy or during any trimester. Platelet counts are often lower than those seen in gestational thrombocytopenia and may fall below 50,000 per microliter. Patients may present with bruising, petechiae, mucosal bleeding, or a history of thrombocytopenia outside of pregnancy. Differential diagnosis: HELP syndrome. HELP syndrome is characterized by hemolysis, elevated liver enzymes, and low platelet count. It is considered a severe manifestation of preeclampsia and typically occur during the third trimester. Patients often present with hypertension, proteinuria, right upper quadrant pain, headache, visual disturbances, and abnormal liver tests. Prompt recognition is essential because HELP syndrome is associated with significant maternal and fetal morbidity. Thrombotic thrombocytopenic purpura (TTP). TTP is a rare but life-threatening microangiopathic disorder resulting from severe deficiency of ADAMTS 13 enzymes activities. Clinical manifestations may include thrombocytopenia, microangiopathic, hemolytic anemia, neurologic abnormalities, renal dysfunction, and fever. Peripheral blood smear often demonstrates cystitis. TTP require urgent hematologic consultation and plasma exchange therapy. Diagnostic test 1. Complete blood count (CBC). The complete blood count is the primary lab test used to identify thrombocytopenia. In gestational thrombocytopenia, the CBC demonstrates isolated mild thrombocytopenia, usually with platelet counts greater than 70,000 per microliter. Hemoglobin, hematocrit, and white blood counts are generally normal. The absence of anemia or leukopenia helps support the diagnosis of gestational thrombocytopenia and exclude other hematologic disorder. Diagnostic test 2. Peripheral blood smear. A peripheral blood smear is performed to confirm true thrombocytopenia and evaluate platelet morphology. In gestational thrombocytopenia, platelet morphology is normal and cystocytes are absent. The absence of fragmented red blood cells help rule out microangiopathic process such as TTP and HELP syndrome. The peripheral smear also excludes pseudothrombocytopenia caused by platelet clumping. Diagnostic test 3. Liver function test. Liver function tests include AST and ALT, are useful in differentiating gestational thrombocytopenia from HELLP syndrome and other hepatic disorders. Patients with gestational thrombocytopenia typically have normal liver enzyme levels. Elevated liver enzymes will suggest an alternative diagnosis requiring immediate evaluation and management. Diagnostic test for coagulation study. Coagulation study evaluate the integrity of the clotting cascade. In gestational thrombocytopenia, prothrombin time and activated partial thromboplastic time are typically within normal limits. Abnormal coagulation results may indicate disseminated intravascular coagulation, severe liver disease, or another coagulopathy and should prompt further investigation. Gestational thrombocytopenia management. Most patients with gestational thrombocytopenia do not require pharmacologic treatments. Management consists primarily of observation and serial monitoring of platelet count throughout pregnancy. Non-pharmacologic intervention include routine prenatal care, patient reassurance, and coordination among the obstetric provider, anesthesia team, and hematology specialists when indicated. Treatments such as corticosteroid or intravenous immunoglobulin is generally reserved for alternative diagnosis such as ITP. Delivery consideration. Gestational thrombocytopenia does not typically alter delivery planning. Vaginal delivery remains appropriate unless obstetric indication necessitates cesarean section. Platelet count should be reassessed near delivery, particularly if no axial anesthesia is planned. Collaboration with anesthesia provider is essential to determine safe platelet threshold for epidural or spinal anesthesia. Patient education and fetal well-being surveillance. Patient education should emphasize that gestational thrombocytopenia is usually benign and self-limited condition. Patients should be instructed to report unusual bleeding, bruising, petechia, or sign of worsening disease. Because fetal risks are minimal, routine fetal surveillance is generally sufficient. Additional fetal testing only indicates when other maternal or fetal complications are present. Referral and follow-up. Referral to a hematologist is recommended when platelet counts fall below 70,000 per microliter, when thrombocytopenia develops early in pregnancy, or when lab findings suggest another etiology. Follow-up includes serial platelet monitoring throughout pregnancy and repeat platelet evaluation postpartum to confirm resolution. Most patients experience normalization of platelet count within 1 or 2 months after delivery.